We are thrilled to be back with you for the Be Well Virginia Town Hall through Northern Virginia Family Practice. It's great to see everybody again. I'm Dr. Cecily Havert. I'm one of the doctors here. Most of you probably know me who are joining this evening. Tonight we have a very special guest, somebody I'm very excited about. This is Dr. Rachel Berger. Dr. Berger specializes in general and nuclear cardiology, as well as echocardiography. And she has a special interest in women's heart health, which is something I'm also very interested in as well. I've referred many patients to Dr. Berger, so we've collaborated in the past. So I'm thrilled that we can work together. A little more about her training. She earned her medical degree from the University of Rochester in New York and pursued her residency in internal medicine at Mount Sinai Hospital in New York City. She then completed her fellowship in cardiology at New York University Medical Center. So when Dr. Berger isn't being a doctor, she's at home with her family. She enjoys spending time with her husband and 3 young daughters. She enjoys hiking, skiing, running, and adventure travel, all activities that are good for our heart, I'm sure. So as everyone has seen this evening, we're using a slightly different format. We are doing the Zoom webinar. Again, we will be taking questions at the end. We'll be using the Q&A feature on your screen. So go ahead. You can put questions in whenever, however, we won't be addressing them until the end. And I think that is most of the housekeeping. So we'll go ahead, since Dr. Berger actually has a relatively long talk, we'll go ahead and just jump right in. So Dr. Berger, thank you so much for being here.
Great. It's a pleasure to be here. Thank you so much for inviting me. I am going to go ahead and share my screen so that you can see my talk. Okay, can you see that? Okay, so I am a cardiologist. I work with Virginia Heart, one of the cardiology groups here in Northern Virginia. I am very passionate about women's heart disease. I would say the majority of my patients are women, and it's been an interest of mine all through my training and into practice. I've done research in women's heart disease. And so what I want to do is provide a bit of an update, some things that you'll know and some things that you may not know about women's heart disease tonight. So tonight I'm going to talk, starting out a little bit about the epidemiology of cardiovascular disease in women. Why is it important? Why do we care? Differences in how women may present with heart disease, a little bit about the different pathophysiology of women's hearts. How are women different than men? And then we'll talk a bit about the risk factors for heart disease in women. We'll talk particularly about dyslipidemia, high cholesterol, and high blood pressure. And then we'll talk about some unique risk factor modification for women. We'll talk a little bit about hormone replacement therapy, the risk that pregnancy may portend for heart disease in the future. We'll talk about calcium supplements, aspirin use, things like that I get a lot of questions from my patients about. So why do we care about heart disease in women? Well, we care about it because it's the leading killer of women. 1 in 4 women will die of heart disease. 1 in 2 women will have heart disease at some point during their lifetime. And in fact, more women than men will die each year of heart disease in the United States. And as you can see from this is a bit old, but even the new ones look similar. Heart disease beats out the combination of stroke, lung cancer, COPD, breast cancer. So really, really an important topic for women to understand. And this is just a graph that's showing the trend of mortality data from cardiovascular disease, and men are in dark blue and women are in light blue. And you can see that around 1985 or so, the lines crossed over and more women started dying of heart disease than men. Now we've done well since 2000, numbers are coming down, but we still have a lot of work to do. So why are more women affected by heart disease? I think that there are a couple of different things that lead to this. Women are more likely to have risk factors for heart disease. Things like being overweight, or having high blood pressure. Women are less likely to know that they have heart disease because they may present differently and they may ignore their symptoms. Women are often too busy taking care of other people that they may not take care of themselves. They're taking care of their partner, their children, their parents, that they may ignore some of their own health issues. And women's complaints may not be taken seriously by the medical establishment. And this is a really, really big problem. There are huge gender disparities in cardiovascular care. When a woman presents to the emergency room with chest pain that may later turn out to be a heart attack, they are less likely to get an EKG, they're less likely to see a cardiologist, they're less likely to be admitted to the ICU than a man. But women are less likely to be prescribed certain therapies like cholesterol medicines and antiplatelet therapies. This was just a study called the Crusade study, which looked at 36,000 patients, 41% of them were women, and they found that they were significantly less likely to get a cardiac catheterization, which is a procedure that you get when you have a heart attack, within 24 hours of being admitted with a heart attack symptoms. They were less likely to get a stent placed, which is something we do in a heart attack, and they were less likely to be referred for cardiac rehabilitation after having heart surgery. And women, in fact, do worse than men do when they're admitted with heart attacks to the hospital. They're more likely to develop shock, they're more likely to have other complications, and they're more likely to have longer hospital stays. And a lot of that is because they tend to present at an older age than men, and they tend to have a higher burden of those risk factors like high blood pressure, diabetes, or chronic kidney disease. Women can also have different types of symptoms than men. So whereas a man may present with heart disease with that typical elephant on your chest, type symptom that you may read about, women can present with more subtle symptoms. Now, women often do present with chest pain, but they might present with just a little bit of trouble breathing. Maybe they're very tired. Maybe they have back pain or jaw pain or think they have a toothache. They could present with some nausea or indigestion. So women can present in more varied symptoms, and so they may not recognize that these are heart symptoms. So before I go further, I'm going to do a little anatomy lesson in what we're talking about. So heart disease in general encompasses a lot of things. And you may know people who have arrhythmia problems, atrial fibrillation, people who have congestive heart failure or valve problems. Really, a lot of what I'm talking about today has to do with coronary artery disease and heart attacks. And so this is a picture of a heart. I think my mouse works for everyone. So this is a picture of the heart. And what we're talking about are these big blood vessels that run down the sides of the heart and supply the heart muscle with blood and oxygen to keep it pumping and working. Through these blood vessels runs blood and the supply of oxygen to keep that muscle functioning. What happens in a heart attack is that you will develop over time a plaque buildup along the edges of those blood vessels. And if that plaque builds up enough that you could restrict the blood flow and oxygen going down the blood vessel, you won't give enough blood and oxygen supply to that piece of the heart so that when you walk or climb stairs or exert yourself and your heart is pumping more and more and asking for more oxygen, you're unable to supply it because you have a kink in the hose. That is angina. That is chest pain that happens when you're exercising or exerting yourself. When you have a heart attack, what you're actually getting is a rupture or a crack in the plaque that exists, and a blood clot forms. And that prevents all blood flow and oxygen from going down that blood vessel. And that piece of the heart won't get enough oxygen and actually can die. And that is what a heart attack is. So we're talking about the buildup of blockages in heart arteries that can cause chest pain and angina. And then that can ultimately lead to a heart attack where you get a blood clot and you're unable to supply the heart tissue with adequate blood and oxygen. And all of the risk factors that we talk about in heart disease, things like smoking and high blood pressure and diabetes and high cholesterol, are all things that contribute to increasing that plaque buildup in the blood vessels and increase your risk of developing a crack in that plaque and a blood clot from forming. So when we go through the different risk factors, that's why we care about those particular risk factors. So that's the general physiology of how heart disease or coronary artery disease occurs. So how are women's hearts different from men's hearts? Women have a lot of that same pathophysiology, but we are learning that there are some unique differences. Women are more likely to be found to have normal, and I put that in quotes, coronary arteries when they go to the catheterization lab with an acute heart attack. What does that mean? That means that when somebody presents to the hospital and has a heart attack and needs to get taken to the catheterization lab to get that blood vessel open, we often find a blockage that we can use a little balloon and a stent and open up the blood vessel and fix the heart attack. More often than men, women are likely to go into that cardiac catheterization, and we go in and we don't see that traditional blockage. And that is something different about women's heart disease than men's. This was a really important study that first looked at that. It was called the WISE study, the Women's Ischemic Syndrome Evaluation. And it looked at 300 women who were enrolled with different chest pain syndromes. They were all taken to have pictures of their heart arteries, and they found that while almost half had a significant blockage that needed to be fixed, almost half either had normal blood vessels or minimal disease. Now, that didn't mean that those women necessarily did better than men. They still had risk of heart attack and death over time. But it was an unusual finding that more of these women presented with non-obstructive blockages in their heart arteries. So the question is raised, why do women present this way? Why is it different in women and men? So there have been a whole series of studies, and research came out even this past month trying to figure out why women are sometimes presenting this way. And there are a couple of different theories that maybe women have the same thing, have that crack in the plaque and the blood clot forms and it dissolves, but their dissolving factors are so much better than men's that we don't see the blockage. We don't see the blood clot when we go in because it's already gone. There are theories that maybe they have a spasm in the heart artery in these women. So there are a lot of different theories about how this could be different. Women are also more likely than men to have what's called microvascular disease. So those are problems with the really, really small blood vessels, not the big ones that we go in when we do a catheterization to put a stent in, but maybe these really little blood vessels that come off of that, those big ones, can have a problem. And because of those little vessels can't adequately provide blood and oxygen to the heart muscle, that might be the problem. And this might be related to a drop in estrogen as women go through menopause, or an increase in hypertension and other things. Routine heart testing is not designed to look at those little teeny vessels, but in women, these tend to be more of a problem. Now, don't get me wrong, many, many women present with traditional heart attacks with blockages that need stents and balloons, but there are subtleties in women's heart care that need us to look at the smaller vessels and the other physiology that might be going on. And this is just a little picture of the small vessels. So these are the big vessels that we see in an angiogram or a cardiac catheterization, but then there are lots of little teeny vessels that supply all the other tissue that need to dilate or open up and let blood flow go through and constrict when they need to. And in women, sometimes these don't work as well. You may have heard about something called broken heart syndrome. It was very popular in the press about 10 years ago. This is something where in the setting of an extreme emotional stress, a woman, often a woman, presents with what looks exactly like a heart attack. And they go in and everything looks like a heart attack. The pictures of the heart look like the heart's not moving. They have chest pain. They might have EKG changes. And they go in to the cardiac catheterization lab and they have normal heart arteries. It's something called Temexubo Syndrome because the heart actually looks like this Takotsubo, which is a Japanese octopus catcher, and has this shape. But it is an interesting phenomenon that we have found is much more likely in older women than in men. And has, because we started seeing this 10, 15, 20 years ago, we started thinking maybe there's something different about women's hearts. So now I'm going to shift gears. So that's a little bit about how men and women's physiology may be a little bit different, and we need to pay attention to different things in women's hearts. Now I'm going to talk a little bit about risk factors for heart disease and how they're important to know, both in men and women. These are a list of the conventional heart risk factors. Age, obviously, family history. So when we talk about family history, we're really talking about first-degree relatives who have premature or early heart disease, high cholesterol, high blood pressure, diabetes, chronic kidney disease, cigarette smoking, being overweight, excessive alcohol intake. These are all the conventional cardiovascular risk factors that you're used to hearing about. I'm going to focus on high cholesterol and hypertension. We know that cholesterol is a big problem for everyone. And in women, about 45% of women above the age of 20 will have high cholesterol. And usually when you get your cholesterol checked, we have different components. We have total cholesterol, we have the good cholesterol, which is the HDL, the triglycerides, which I like to think of as the fat in the blood, and LDL, which is the bad cholesterol. And that's the one we really target when we're trying to decrease risk for heart disease. In women, we find that having a low HDL can be more predictive of cardiovascular disease risk. And so that's why your doctor may talk to you about your ratio of the LDL to HDL. It's not quite as much in vogue right now to be looking at that, but HDL does, particularly in women, need to be taken into account. There's also a lipoprotein called lipoprotein A, which we often find elevated in patients who have a very strong family history of heart disease, particularly at a young age. And it's a big determinant of cardiovascular disease risk in women, in younger women, and can be independent of other risk factors. So that may be something else that we would check in a woman. But again, LDL is the primary lipid lowering target. And we do that with lifestyle. We do that with statins, Lipitor, Zocor, Crestor, those type of things. But women are largely underrepresented in these studies. So just in the more recent studies, they're trying to include more women, but the older studies that a lot of what we do is based on really didn't include enough women. This is just to remind me to tell you that the cholesterol guidelines did change in 2013. So we used to say we're trying to get your LDL to a certain number. Now we really focus on getting people on the right dose or the right amount of a statin. There are 4 major groups that are identified to benefit if you have known heart disease or stroke, if you're diabetic, if you have an LDL or a bad cholesterol above 190, or if we calculate what your risk in the next 10 years of heart disease is, and it's more than 7.5%, these are all people who would benefit from being on statin therapy. So there are different risk calculators that I use to determine if somebody for primary prevention, meaning they haven't already had a heart attack or a stroke, would benefit from being on a cholesterol medicine. And that incorporates all of these different risk factors. And I use that, I have it on my phone, and I frequently use that with patients when they're coming in and we're trying to decide if they need to be on therapy for their cholesterol. For women, there's a risk score called the Reynolds risk score, which is found to be a little bit more accurate in women than a traditional one. And it's similar to the usual one that we use, but incorporates something called high sensitivity CRP, which is a marker of inflammation. And it also incorporates family history. So it's a little bit different than the traditional one. So that's a little bit about cholesterol, one of the major risk factors for heart disease. And now I'm going to talk about high blood pressure. High blood pressure is really important, particularly in women, and getting that under control is important in terms of decreasing your risk of heart disease later on. So 70 to 80% of women above the age of 60 have hypertension. It's a strong independent risk factor for the development of heart disease. And among premenopausal women, having hypertension increases your risk of heart disease mortality by more than tenfold. So really important. This is just a graph of what normal blood pressure has traditionally been thought to be, which is less 120 over 80. And then the 2 different stages of hypertension that I'm sure y'all are familiar with. 130 to 140 over 80 to 89 is considered stage 1, and stage 2 is above 140 over 90. A new study came out last month in Circulation that raised the question as to whether women actually need to have a lower target blood pressure than even 120 over 80. It looked at almost 30,000 patients from a couple of different big community-based cohort studies that they followed over 30 years. And they were looking to see whether different risk factors increase people's risk over 30 years of developing heart disease. And they found that while men had an increased risk with a blood pressure that was more than 140 or 160 for the top number, women actually had an increased risk with a much lower blood pressure, something even between 110 and 120, which begs the question, is this a one-size-fits-all approach to have the same guidelines for men and women? And maybe women need to have even lower blood pressure targets than men in order to reduce their risk long-term of heart disease. So really important sort of hypothesis generating study. Guidelines haven't changed and haven't reflected this, and it needs to be studied more, but it does raise the question that should women and men have the same target blood pressure? I mean, women tend to have smaller blood vessels. They are smaller, so you would think that the same blood pressure in a man and a woman might affect their bodies differently. And these are some things I give my patients in terms of non-pharmacologic ways to lower blood pressure, obviously weight loss, a heart healthy diet. There is a diet called the DASH diet, which is scientifically proven to lower blood pressure, lowering your sodium intake. So trying to stay under 1,500 or 2,000 milligrams a day of sodium, increasing your potassium intake. These are all things you can do to lower your blood pressure without medications. Increasing your physical activity, lowering your alcohol intake. And if you have sleep apnea, treatment of sleep apnea can be really key to getting blood pressure under control. And this is just a graphic on how we treat and when we use medications versus non-pharmacologic therapy. And this is just a picture to talk about all the different things that we need to focus on to get blood pressure and cholesterol and decreased heart disease risk. So cutting the salt, increasing the exercise. I tell my patients at least 150 minutes a week of moderate intensity exercise, meaning getting your heart rate up. However you need to do that. You can dance, you can do Zumba, you can walk or bike. It's about getting that aerobic exercise in. Watching your diet. Mentioned the DASH diet. There are a lot of Mediterranean style diet, a lot of different ways to lower your heart disease through adjustments in diet. Lowering your alcohol intake. So women really shouldn't be drinking more than 1 alcoholic beverage a day. Smoking cessation. Managing stress, which is always difficult, especially in this day and age. And lowering your weight. And then just to touch upon a couple of unique things for women in cardiovascular disease. Menopause is obviously a clear risk factor for the development of heart disease. So early menopause has been associated with an increased risk of heart disease. And after menopause, we always see cholesterol going up, blood pressure going up, risk of diabetes and heart disease. All of this increases after menopause. The Women's Health Initiative was the big study that gave us the most data on use of hormone replacement therapy in women. And I'm not going to go through the details of it, but it looked at that. It also looked at lots of other things like calcium and vitamin D and different diets and how that affected women long term. And it found that the hormone replacement therapy arm ended early because it did find that there was an increased risk of breast cancer and heart disease. But when they looked at that carefully, it found that it was really in the older subset of women that this most affected. So when patients ask me about hormone replacement therapy, the general feeling from the heart standpoint is that certainly within the first 5 to 10 years after menopause, hormone replacement therapy can be very useful in controlling symptoms and other things. It can be beneficial in osteoporosis risk prevention, hip fracture risk prevention, etc. What we don't want is people to be left on hormone replacement therapy for years and years and years and it not to be reassessed because it can increase the risk of heart disease and stroke long-term in older individuals. So this is something that you should talk about with your primary care provider, perhaps your gynecologist and your cardiologist if HRT is something that you're considering. Little touch on pregnancy. There has been a lot of data that's coming out recently that women who develop preeclampsia have twice as great a risk of developing cardiovascular disease later in life. Pregnancy is like a stress test for your body. So sometimes we see things during pregnancy that we just need to keep a closer eye on as people get older. Gestational diabetes similarly. And then lastly, I'm going to talk about a couple of things that I get questions about frequently. Things like calcium supplementation. We all know that we need calcium for our bones, particularly women, and risk of osteoporosis. So that Women's Health Initiative data that looked at 36,000 postmenopausal women and randomized them to calcium and vitamin D or placebo. And they looked at what their risk of heart attack and stroke was if they were on calcium and vitamin D. And this found that after 7 years, there was no evidence of increased risk. There have been more studies in recent years. Some say calcium supplementation is not good. Some say that it's okay. My general feeling about calcium supplementation is that if you can get calcium in your diet, it's always better. So whether it's through, broccoli, leafy greens, cheese, milk, yogurt, things like that, it's always better. But if you need to take a calcium supplement, it's okay up to about 1,200 milligrams. That's my own personal feeling. There have been some studies recently that are looking at calcium supplementation and risk of developing coronary calcium and things like that. I still think that the benefit of getting calcium in outweighs that risk. And these are just different things. You can get calcium in sardines, low-fat yogurt, orange juice, kale, broccoli, figs, things like that. Omega-3 fatty acids, that throughout my career has gone in and out of favor. I think that it is useful for lots of things. As far as for prevention of heart disease per se, it has not been proven to prevent heart disease by taking omega-3. We do encourage people to eat fish, salmon, mackerel, king mackerel, things like that, that increase your omega-3 intake. High doses are used with patients with high triglycerides, but in general, I don't have all my patients taking omega-3 as a supplement. Aspirin use, also big in the last year or two. Certainly all patients who have had heart attacks or strokes should be on aspirin. It's the primary prevention data that has been changing over the last 2 years or so, and really recommend you talk to your doctor about what category you fit in. Are you at increased risk for heart disease? Are you at low risk for heart disease? The general feeling is that we used to tell everybody that they should be on aspirin for prevention of heart disease. We don't say that anymore because we really do look at the risk that aspirin increases your risk of bleeding and ulcers, and it's not a completely benign medication. So there are certainly people that I do keep on aspirin because of their heart, their risk of developing heart disease, or they may have some plaque that has been seen in different studies. And I will certainly keep those patients on aspirin, but it should not be used diffusely for all patients without considering the risk-benefit ratio. So take-home points. Hopefully I didn't bore you all to death. Heart disease is the leading killer among women. Women can present differently and are often treated differently than men, so be aware of those different types of symptoms. Advocate for yourself, because we, as a medical establishment, may not be doing a great job at taking women's complaints as seriously as we should. Women's hearts really may be different. There may be different physiology. The small vessels may play more of a role. More women are presenting with heart attacks in normal heart arteries, and we're trying to figure out why. There are conventional and unique risk factors for women's heart health. Pregnancy, menopause change some of the things we think about, and addressing those unique factors help people like myself and Dr. Havert take better care of women's hearts. And that's where I will end.
Okay.
Hopefully that was useful.
Great. Thank you so much, Dr. Berger. I actually learned quite a bit too from that talk, so I appreciate you sharing that with us. I guess now we're going to switch on over to some of the questions. A few of them have already come in, but those of you who want to throw some questions into the Q&A, go ahead and type those in. I understand that some people are calling in, and unfortunately, we're not going to be able to take audio right now. However, what you can do is there is an email that's on the invitation that goes right to Northern Virginia Family Practice. So those people who are not able to send their questions tonight, I invite you to go ahead and use that that Gmail account. That's all that's in the invitation to go ahead and send those questions, and we'll see if we can get those answered. But let's go ahead and just jump into some of the questions for Dr. Berger. All right, so we've got a question here. Is AFib considered heart disease? This person says, I've had AFib and had an ablation. I'm wondering if this will fix the heart rate. So this is a little, I always talk about the difference between the plumbing of the heart and the electrical part of the heart. And can you talk a little bit more to that, Dr. Berger?
Absolutely, I use that.
Well, great.
So what I was mostly talking about was plumbing of the heart. So when we talk about heart attacks and coronary artery disease and blockages, that's the plumbing. AFib is an electrical issue. We have cardiologists that we refer to as our electricians within our practice. Atrial fibrillation is an arrhythmia. It's an electrical issue with the heart where there is an irregularity of the heart rhythm. So normally the heart rhythm is very circumscribed. It goes down a specific set of electrical wires, and every time it goes down those wires, the heart contracts. In atrial fibrillation, instead of a very clear wire, you're getting a lot of electrical impulses, which are causing the top chamber to do more like this. And so you have an irregular heartbeat. It is heart disease. It is under the umbrella of heart disease. It's just more of an electrical rather than a plumbing issue within heart disease.
Okay, and treatment is basically trying to get that electrical rhythm to go back into a healthy rhythm. And so I think this person had mentioned that she got an ablation and she's wondering if this will fix the heart rate.
So atrial fibrillation, some people are in it all the time. We call them chronically in atrial fibrillation. Some people go in and out of atrial fibrillation throughout their lifetime. When we think about atrial fibrillation, we worry and think about a couple of different things. One of them is the risk of blood clots and stroke. And I'm sure you've all seen the ads on TV for Eliquis and Xarelto and the different types of blood thinners. So we do look at that and whether someone needs to be on a blood thinner. We look at if they are in atrial fibrillation all the time, are they having symptoms from that? And do we need to be on medicines to slow down the heart rate so that they're not having symptoms? And then we look at whether we want to try and get them back in a regular organized heart rhythm. And one of the ways that we do that is by doing a procedure called an ablation, which is it's a procedure that you have to do in the hospital where we go in and we try to separate where those electrical impulses are coming in from the rest of the heart so that the AFib is basically cured. There are also medications that we can use to try and do that if we're not interested in doing a procedure. So there are a lot of different things and treatment options for AFib.
Okay, thank you very much. We'll move on to the next. I think you answered this in your in the talk, but we have a question: are 2 to 3 glasses of wine per night on average bad for you?
So there's data in lots of different literature. There's data in breast cancer literature. There's data in other literature that minimizing alcohol intake is important. So generally speaking, for women, we say on average 1 glass is probably better, and for men 2 glasses is up to 2 glasses is okay. So I would say 2 to 3 glasses for a woman is too much, and it does increase your risk of high blood pressure and heart disease and other things down the road.
Okay, thank you. Next question. You had mentioned in women a lot of the concept of microvascular disease, how that differs from men, some of the thinking behind that. And we have a question of what kinds of tests are being developed for microvascular disease, either for diagnosis or maybe even for treatment?
That is a great question. So the conventional things that we do, like a catheterization where we go in and we inject dye in the arteries, we're really seeing the big vessels. Even CT scans that we do, we really see the big vessels. So a lot of what we do looking at the little vessels is more using technology like MRI and PET scanning, and it's more done in more academic centers to try and get a better sense of those smaller vessels. And we use medications like we do in stress testing to try and challenge those little vessels and see if they open and close appropriately. But it's not something that's always available in routine offices and practices.
Okay, all right. Next question. What type of vitamin would you recommend for women over the age of 45? Any particular brand?
Personally, I think that a well-balanced diet should be sufficient. So I think if you eat lots of fruits and vegetables and whole grains and you're eating a good, well-balanced diet, I don't think you need to have an additional vitamin. I do think that talking about your calcium, thinking about your calcium intake and your vitamin D are the two main things that I would focus on. But that short of that, I leave that to the internists.
Yeah, and I was going to say, I mean, I get obviously asked that question a lot, and I agree with you, Dr. Berger. There have been some studies out there that really show that there's no major benefit from just a general multivitamin in improving, longevity and decreasing mortality. However, if there's deficiencies in certain vitamins, or maybe your diet is not as good, you can focus on some of those. But for women especially, and men as they get older, the calcium and the vitamin D are the two that at least I like to focus on, and telling people just to make sure that in their diet they have adequate. If they want to add a multivitamin, it's up to them, but I don't have any particular preference for a brand or anything like that. So, okay. All right. Just had to add the family practice input on that. Okay, another question. Would you talk a little bit about the DASH diet as far as efficacy and how easy it is to use?
So the DASH diet, I'm getting a little bit of an echo here. The DASH diet is, it's a diet that was studied years ago. It's been around for a while, but it basically is a low sodium diet. It's high in potassium. It's mostly foods that you would normally eat. It's not an obscure diet in any way. But it helps to enhance some of those things and keeps in mind the low sodium, high potassium intake. If you could Google DASH diet and you can get a list of the different things, but it's whole grains, it's fruits, vegetables, proteins, what you would imagine a heart healthy diet would be.
Okay. Another question, getting back to some of the electrical questions about the heart. Can atrial fibrillation be prevented, especially if it runs in family? Is there something that runs in families? Is there something genetic about it? And is there anything we can do to prevent this?
Good question. So there is a genetic component. So we often do see it run in families. As far as prevention, certainly keeping your weight down, so not being overweight. Treatment of obstructive sleep apnea can certainly help prevent atrial fibrillation. But short of that, just all of the routine things, making sure your blood pressure is good, that you are eating a heart healthy diet, that you're not smoking. I mean, all of those things can help prevent it long term. But most specifically, I think is the weight, the blood pressure, and the sleep apnea.
Would you say that alcohol sometimes plays a role in atrial fibrillation? I've seen that reported also. And so cutting down on alcohol, or just
cutting back,
not using it at all.
Yeah, no, we see that. There was a whole thing called the holiday heart that I'm sure you saw in your residency. So people who have drinking binges and then go into atrial fibrillation, we see that. But we also see it associated with people with increased alcohol intake. Absolutely. So, cutting back to that 1 or 2 drinks per day is useful in that regard.
Okay, thank you. More about supplements. Is a magnesium supplement helpful for women's cardiovascular health post-menopause? Could you speak a little bit about magnesium?
So usually I use magnesium in 2 settings. One, I'll recommend it if people are having a lot of palpitations. So meaning they're feeling their heart flipping and they're diagnosed with, perhaps early beats, premature beats. Sometimes that can help those. And then sometimes I find it useful in patients who are having a lot of leg cramping, but it's not something I would routinely give to all postmenopausal women.
Thank you. Here's a question about postpartum. So it's sort of a long question, so I'm going to kind of break it down here a little bit. So what is happening to women postpartum when they have an episode of acute chest pain lasting a couple of minutes? Now, I think that could be a lot of different things, but I'm assuming that they had a negative workup. I'll answer for women postpartum. One of the first things we think of if you're having chest pain and shortness of breath probably is not the heart, unless there were heart problems during pregnancy. The first thing we're going to probably think of is something happening in the lungs. So I'm assuming that that's probably been ruled out. But are there any conditions postpartum? I know you talked about preeclampsia as being a risk factor for heart disease, but that's later on, isn't that correct? It's not right after pregnancy that's correct.
It usually presents in the last trimester or last few weeks of pregnancy. And then, the other things that we see are high blood pressure. So we do see patients who develop high blood pressure either at the end of pregnancy or postpartum. So we would want to know what that person's blood pressure is. But like you said, we would worry about lung problems. We would worry about acid reflux. We would worry about, those type of things. There are some unique things in women's heart disease and pregnancy that, things like spontaneous dissections of the arteries and weakening of the heart muscle. But these things are extraordinarily rare, and they usually present in a very obvious way. So, I would look for other things in somebody who just developed some chest pain after pregnancy.
Yeah. Usually a lot of times in medicine, we know what it isn't a lot quicker than before we know what it is. And so part of our job is to sort of rule out the very scary things, the things that are really going to impact. And, sometimes it's, once we've ruled out the scary things that are going to, negatively impact your life, sometimes we spend a long time trying to figure out what it actually is. And sometimes we never do figure out what it is. And I think there was one other question just about this also, talking about the spasm or collapse of the artery. I think that she's talking about just the vasospasm. And if you could talk a little bit more about that, and if that could be related, is that something that could be related to pregnancy?
I don't think we see a lot of coronary spasm per se in pregnancy. Women tend to have more coronary spasm than men. And that can present as, severe chest pain. You think you're having a heart attack, and they go in and they see normal arteries, and we can actually try and initiate a spasm and see how reactive the blood vessel is. So we definitely see more coronary spasm in women. I wouldn't say that that's really increased in pregnancy per se, but it is something that, we would want to be aware of.
Okay. Again, back to some supplements here. Is there danger in taking a calcium supplement? So I guess this person is wondering if they should stop taking their supplement. So I'm not sure how old this person is, but could you just speak again to the recommendations you made about calcium and maybe in relation to the Women's Heart Initiative?
Yeah, I don't think that there is an overt danger. There's been some controversial literature recently looking at, are people more likely to develop plaque on CAT scans and things like that if they take too much calcium? I certainly think up to 1,200 or 1,400 milligrams a day of a supplement is not going to harm you. Again, better to get it through your diet, but if you can't get it through your diet, I think that it's absolutely okay to take up to that amount.
Yes.
Do you agree from a primary
from a primary standpoint? That's exactly what I tell patients. I say try to get it in your diet, and try to teaching what types of foods contain good calcium, and then and if you have to, my goal is to try to get them for postmenopausal, well, most women, but especially postmenopausal women, between 1,000 to 1,200 milligrams a day, most of which in diet, but then you can take maybe like an extra 500 milligrams a day. Sometimes we find that if you take too much calcium, you actually don't absorb whole lot of it either. And so you want to make sure, so the dietary forms of calcium, you're going to do a better job of absorbing, your body's going to use it better.
Yep.
So that's in my, that's usually what I tell people, and in my reading, that's what it is. I have some questions, or just maybe a question, Dr. Berger. So in primary care, well, in all fields of medicine, we order a lot of blood tests, and when we order the cholesterol panels, at the physicals and everything. And you were speaking a little bit about lipoprotein A and also the ultrasensitive CRP. At what point do you order these? Are these routine labs? Do you choose certain people to order these on?
I don't order for all people. I will choose to order an HSCRP or a lipoprotein A in patients, particularly who have very strong family histories. And I am, concerned that part of their family history is a lipoprotein A problem. There are more recent guidelines that say if their risk falls between 5 and 7.5% chance of having a heart issue in the next 10 years using one of those risk calculators, that use of those type of things like HSCRP or lipoprotein A can help skew you towards treating them more aggressively with statin therapy. So I'll do it in patients who fall into that sort of intermediate risk area. But it's not something I would routinely screen because it's sometimes difficult to do something with it, because HSCRP in particular can be elevated for other reasons. And so sometimes we get stuck looking for signs of inflammation and we don't really know what to do with this number. So I try to use it when I think it's going to change my management. And it could be useful in helping me to determine if somebody should be treated a certain way. Lipoprotein A also, we don't have great treatment for lipoprotein A lowering. We are enrolling, our group is enrolling in a trial for people who have high lipoprotein A to try medication to see if that helps outcomes, but we don't know yet if it's useful. So I don't do it on all patients, but I do it in select patients, usually people that have suspicious lipid profiles or family histories.
Thank you. That's helpful. And I just want to invite more, if anybody else has any other questions, you can go ahead and put them in the Q&A. I think we have a couple more minutes here. So if anybody wants to write anything more, I think that we've answered most of the questions at this point. So, okay, all right, well, if there's no other questions, we can probably go ahead and just start wrapping this up. So anyway, I want to thank everybody for joining us again this evening at the Northern Virginia Family Practice Town Hall. It's great to see everybody again, and you're welcome to our new format. Hopefully people found that this was okay, and especially a big thank you to Dr. Rachel Berger from Virginia Heart, cardiologist, for coming in and speaking with us. In the future, we're going to be having more town halls. The next one that we have, I'll just mention really quickly, is we have a mental health, which is one of my favorites, and a mental health town hall that's coming up on March the 16th. We're going to be talking about healing from trauma. We're going to have a therapist on, Francine Ronis. I think that she was on last summer when we talked about some other anxiety issues related to COVID. So we're going to have her back, and we're going to talk a little bit more specifically about healing from trauma. So, a few more questions rolled in. Here's somebody that says, thank you, great, informative, so thank you. Okay, one more question. We'll make this one be the last one. This person is interested in hearing a bit more about the relationship between inflammation and heart disease.
I would say they're intimately related. We are learning more about this every day, but the pathophysiology I was talking about of a heart attack is that you're getting inflammation in that plaque buildup in the artery that then ruptures and causes a blood clot. So even in that little bit of heart disease, like, we know that inflammation plays a huge role. So statins like Lipitor and Crestor are medications that help us not only because they lower cholesterol, but they are also great anti-inflammatories. So that's one of the reasons why they decrease your risk of heart attack and stroke later on, is that they decrease that inflammatory process in the plaque. So, there's a lot of talk out there about anti-inflammatory diets and different approaches to decreasing inflammation. I am not an expert on that, but I certainly think that there's a lot we don't know at this point. I think that as the years progress, we're going to learn more and more about how the levels of inflammation in our body, how stress, how what we're eating is all impacting heart disease.
Yep, I couldn't agree more. I think this is the tip of the iceberg. Figuring out how inflammation and diet affects our health, and hopefully we'll have a lot of good approaches to making everybody healthier in the future once we know more. So
yeah.
On that note, we'll go ahead and wrap up. And I know that there have been a couple other questions that have come in, and that's great. I'm going to go ahead. We're going to actually record all the questions, and anything that wasn't answered, we're going to go ahead and send to Dr. Berger, and she's thankfully said that she was going to go ahead and answer those questions for us. So we'll get the answers back to you on our website underneath. When we post this video, there'll also be a link to the questions as well. So anyway, I want to thank Dr. Berger one more time. Thank you so much for coming this evening. Thanks for being with us. And good night to everybody. And I hope we see you at our next town hall. Good evening. Bye-bye.
Yeah.